We decided to do 5 minutes of panel discussion. I'm going to ask the panel members for 60-second responses. So, rather than starting, Mehdi, let me start with you, Tino. You showed all this great imaging. When do you go straight to angio?
I think the best time to go to the angio is one when you have a patient that is renally challenged and you're going to go with CO2. A lot of those patients that go straight to angio. Sometimes your duplex map is pretty damn good, and you need to and you basically are very limited. You know that you're not going to get the best images, patients that are moving, and no matter if you get them in the scanner, you're not going to get a good image. So I think those are the ones that I go straight to angio on. But I have to say it's few. It's few that I go straight to angio. CO2 is probably my number one reason.
I think maybe the other question to ask is that not when you go to angio, it's are there patients that we discuss these issues of hemodynamics and all of that, and people a lot of times when we present this, folks say I go straight to angio. I don't waste my time. I know ABI is not accurate. TBI patient has an ulcer. I should get an angiogram. So I guess the question to ask is that is there a way to do the hemodynamics, get some data so you can use it for follow-up, but then, don't delay the treatment. I mean, there are folks out there that advocate, angiography for all patients with CLI. I mean, what do you think, Tony? Do you agree with that?
Me?
Yeah.
Yeah. So here's my approach to this. I don't understand CT enough for really using it on every single case, because every time I have a case where CT shows me that there's very little to be gained by an intervention, and we say, look, there's really nothing to lose here. The patient can either get a CO2 angiogram or get a selective tibial angiogram. Actually learn a lot at the angiogram, and mostly what you learn is that there are revascularizable options. And I think that that's the part that kind of keeps me from stopping at the CT or the MR, because I don't know that we've really given them enough of an evaluation. Because when you correlate those two things, you frequently find what look like hibernating areas that you can revascularize. And the imaging of, bolus injection and chase during a CT or an MR doesn't always get to these places. So I hesitate. So I use duplex and then an angio most of the time.
Yeah, I would say that you're correct. And I think CT, what it gives you is a map of what you can see. But you have to know that there's vessels you can't see. Even that MR with the time resolve that I showed you, I think is great. But there's still a lot of little vessels you're not going to see. But it allows you to figure out, where am I going to approach this? What am I going to tackle? And I think that just gets you ready to go. But I agree with you in terms of that. You're going to see a lot more, and our techniques are much better than
I will use it when there's an aortic stenosis, or an aortic stents or an aortic bifem where I know I've got to change my approach to getting to things. That I think that's a really good reason to use CT as well.
Let me switch gears and ask another question. Start with Mehdi. So, we kind of touched upon perfusion as being more important than flow. So, anatomy allowing, what are your endpoints for a CLI intervention? And how will new tech such as Perfusa, Pedra, the laser tech, and Christie change those endpoints?
Well, for me, I think that the endpoints are changing. I think the focus may have been 10 years ago on amputation-free survival and male. For me, is that what is it that we can do to try to heal the ulcer as fast as possible? And I really don't think that when we talk about these amputation-free survival graphs, to me, really, they don't mean much. Because if you have two patients and, one heals in a month, the other one has the wound for 2 years, and we see patients like this all the time, 6 months, 8 months, and both of them did not get an amputation, but, one healed in a month, one went for 8 months. In regards to the endpoints, I think we are struggling. We don't know. In a sense that, the hemodynamics, we just actually looked at our cases and have a paper in press in JACC intervention. We looked at the changes in TBI before and after procedure, and we found out that the changes in TBI, despite doing extensive work in the tibial vessels and doing all this fancy stuff, is only 0.18. 0.18. That was the median. So really, how much perfusion, how much changes are happening at the microcirculatory level, and how can we improve that to try to heal these wounds faster? Well, let me turn it to you. What do you do? You're also, doing all these intraprocedural injections and trying to understand how far to go.
Yeah, well, we don't believe in angiosomes. We use angiographosomes, which is very distal selective injections, as was brought up here, to really define the anatomic pattern of perfusion to a wound. And almost all wounds have multiple vessel contribution. They're all watershed. That's why they got the wounds in the first place. So, we rely on multi-vessel revascularization. We use wound blush as possible, and when we're unsure of the vascular contribution, we're doing methylene blue angiography to determine if a single tibial vessel, has any contribution to a particular wound. But I think you're right. We're going to sort of move away from the idea of target of opportunity to multi-vessel revascularization when possible, as anatomy allows, really sort of looking for clear indications of perfusion. And, Viva, through the Vascular Leaders Forum, has a anatomic proposal which includes such things as wound blush and perfusion measurements, which needs validation. So.
John, may I add something? I just want to say this because at every meeting when we discuss about CLI, the discussion ends up in angiography, no angiography, CT, no CT. I think because it goes towards the direction of intervention. And I think the reason why 48% of patients get amputation and have no evaluation before this, because I think all meetings and all societies need to speak to those who are sitting on those patients. And I think we need to provide some very consistent approach of how to triage this patient. I can just recall one very important statement Mehdi said yesterday, that there is no neuropathic ulcer, there is no any kind of venous ulcer. Ulcers exist and they do require an ischemic evaluation. There should be a consistent approach of doing so. I think if we do that, we will probably gain as an interdisciplinary team.
Well, I think with that, let us end because we are already 6 minutes over the time. I want to thank everybody for being here late in the evening and enjoy your happy hour.
Thank you.